Mukherji. I'm an ER doc from New York, and I'm very sad right now that I put in this abstract. It's really ruined my morning. Looking forward to this. But I'm going to tell you a bit about diagnosis, and it starts here with the Institution of Medicine report on error. And the breaking news was there was a lot of them. No one was very happy about this, and that set up the next 16 years of trying to make this better. How did we do that? There was a lot of attention towards cognitive errors, mental lapses that doctors might make, and we had these debiasing strategies, and we'd hope that this would make a difference. There was also a lot of attention towards systems errors. You know, doctors are human. Mistakes happen. We shouldn't expect them to be perfect. Why don't we construct a system that makes the mistake less likely? So this is the Swiss cheese model. This is for a mistake to get to the patient, it's got to leak through all these safeguards. So really what you need is just one more layer of cheese. Now, I have a training program for emergency medicine. I teach new interns just out of medical school. And in 15 years, there has never been a year that an intern did not come up with a new and wildly innovative way to screw something up. So this pattern of let's never make this particular mistake again, I never thought was a wonderful way to do it. Where are we now? Well, in 16 years, we haven't moved the needle. And we haven't paid attention to diagnosis. So we are at 20% misdiagnosis, which leads to delays in care and wrong treatments. And we are up around 10% of mortalities related to misdiagnosis. And that's kind of a big deal. And that's a number that, from the September 2015 report, was higher again than doctors had expected. So why don't we invert the question? Instead of learning from each individual error, and let's never do this one thing again, why don't we copy the people who get it right? In a training program, I have interns standing next to supervisors who are experienced physicians. And they do it faster, they diagnose more accurately, they're able to pull out the patient complaints in a way that's meaningful. Can't we all do that? So those experts got good judgment from experience, from bad judgment. And how can we accelerate this without repeating their mistakes? What if we train the docs with the habits of those experts in mind? There are three things we can do, in my opinion. One is interpretation. Two doctors hear the same exact story, and one says, this patient's having a heart attack, the other says, no, go home. What happened? There's a disconnect here. How can we make that mental processing transparent? So there's a technique called script concordance testing, and it works like this. I give you a single variable, and you tell me how much this moves your needle. Is it much more likely, less likely, or kind of a wash? And it would work like this. My patient with chest pain has pain that also goes to the left arm, and my novices would go, yeah, I've read about that. That's your heart. But my experts would go, actually, it doesn't matter that much more than just plain old chest pain. I was already worrying about the heart. And they give it a 0. Whereas if I said chest pain to both arms, my novices would say, that's weird. That's not right. That's not a heart attack. And my experts would say, well, it is weird. It's atypical. And it's about 4 times more likely to be a heart attack. And the evidence bears out those experts. So we have to teach that critical data weighting. We also need to teach just one thing. We like to teach in medical school 10 things that make this diagnosis more likely. Because we like to pimp medical students with lots of questions. It makes us feel very smart when we're able to rattle off these answers. But does it make a difference? Well, the problem is it groups things similarly so that you recognize similarities and don't recognize the one different thing. And that's important. And we have to thank Nate Silver for this terminology about the signal and the noise. Because when I tell a patient, I want to hear your story, I want you to not leave anything out, I'm still not giving all those things the same weight. It might be that that third toe tingly that happened last month really is not germane, and I'm not going to listen to it. But what if I taught that as the square peg, as the not fit element? That would prime the doctor's brain to actually sit up and listen and go, you know what? Toe tingling with chest pain, that might not be a heart attack. That actually might be a vascular problem, an aortic problem. It gives the doctor permission to get off that incorrect diagnosis. Which experts do. And the last thing is feedback. Doctors are predictors, just like weathermen. We look, and we look for the sharks, and we say, I'm going to investigate this, and then they really don't get great feedback on how many sharks there actually are, and things that don't turn out the way we expect. We need to give doctors feedback that's actionable. So how do we do that? We have M&M conferences, and we investigate these cases. Now, in this scenario, a patient is telling her doctors what happened to her. And that is very different. When my administrator tells me, hey, Mukherji, I think you screwed this case up, my brain immediately goes into defense mode about, you're not a clinician and you weren't there, and I have a special artistic gestalt with my patient, I know better. But when a patient says, because you did this, I spent an extra week in the hospital, well, you can't really argue that. And conversely, when a patient says, you know, I've been to your hospital 4 times, and this time it was such a different, better experience. Whatever you did, do that again. You give doctors actionable items. So that's it. Diagnosis is job 1 for me. I'm an ER doc. And we can do that by teaching critical weighting of decisions, by giving you just one thing, disconfirming evidence, not confirming evidence, and making better predictions with patient feedback. So that's what I got. Thank you very much.
Excellent, thank you. I'm not letting you leave the stage, so I'm blocking you off here because I've got a couple of questions for you. So what you're really talking about is systemic problems rather than, you know, like, so we study the one thing, one time something went wrong, but you gave a great talk and you mentioned about how students always invent new ways of stuffing up, and I'm sure your expert people can also do the same. So do you see it as systemic issues that can be addressed?
I think that there are certain kinds of errors that that Swiss cheese model works really well for. And they still have to be recognized as kind of stopgap elements, that this particular error won't happen. We also downplay the unintended consequences of all those layers. When we complain about the wait times and the bureaucracy and the paperwork, we invent those things to prevent this one bad thing. Honestly, if there's 2 things in huge abundance in the universe, it's hydrogen and human error. You can't really plan for those things, yeah.
Yeah, and interestingly, I always find the term adverse events, because it's a strange one, because in my background, I actually started life working in the mining industry. And if you work in the mining industry where it's, you know, it's recognised to be unsafe, there's all sorts of things that can kill you, chemicals, compounds, big trucks that the wheels, you know, are way up here, that sort of thing. They have a zero tolerance policy for what we term adverse events. And they take it very seriously. And yet in healthcare, you'll see, you know, doctors or healthcare administrators on stage proudly saying, hey, guess what, guys, we killed less people this year. Yeah, and I don't mean to be flippant about it, but that's actually what happens. You know, we basically have an acceptance within healthcare that people will experience adverse events, and then there's people like you trying to change that situation.
I think it's a really complicated question you're raising, because on the one hand, when a bad event happens and it is a death, it's seen as the tip of the iceberg. What about all the people who could have had this event? How many people have to actually die in the coal mines when everything kills you? Everything is this terrible event. But then the opposite of that, trying to make it go to 0, is probably impossible. And we have to take care not to harm patients trying to do the impossible. Perfect is the enemy of good.
Yes.
And that's a tough one.
All right, I have one more futuristic question for you, because this is Medicine X, where we talk about all sorts of things on stage. Yesterday we were talking about my uterus, but I won't do that to you. So
we can talk. It's fine. We're
okay,
open
cool.
community.
All right, very good. So what I'm going to ask you, though, is artificial intelligence. So I mentioned yesterday, so there is a thought within the artificial intelligence community. We've got companies like Google, I think, own something like 14 AIs, and you've got IBM's Watson. Do you see a future where children born today won't actually be diagnosed by a human doctor, but will be diagnosed with an algorithm, and then the human comes on after that? What do you think?
I think that the analogy I would make is chess, the Kasparov deep blue thing that we've been talking about for a long time. Right now, AI like Watson can do certain things way better than I can do, that I cannot compete with. And at the same time, right now, the combination of a human amateur chess player and a good AI can probably beat either or, a grandmaster or a machine. And I think that's where medicine is going to go. There are certain algorithms, just like the systems model, that are going to work very well for certain diseases, and aligning that treatment with the disease is going to be Watson. But the doc's going to have to figure out if it's the disease. The right treatment for the wrong disease is never going to work. So I actually think that for good or bad, the human element of doctoring is never going to go out of business. And 5 talks at this MedX around design and patient-centered and communication are going to corroborate that.
Absolutely. No, I agree completely. Thanks very much for your talk, and thanks for letting me ask you some questions impromptu as well. Cool. Thank you.